Good evening, participants and delegates. Thank you for joining today with Shield Connect. So today we came with a new topic on our platform with a doctor from Assam. So the topic is Idiopathic Pulmonary Fibrosis, and the webinar educational initiative is sponsored by Rudibin Mu AppCode Progenics, and speaker for the day is Dr. Mrigank Madhav Mishra. Sir is MBBS, MD, and FRSM from in pulmonary medicine from Dibrugarh, Assam. So before we start with the introduction of our speaker, let me give a quick idea about our page Shield Connect. So this is our page shieldconnect.in, where you can see we have recently got 5 awards on digital platforms category for women's health solution. And this is our sections available. So the first section is the blog section, where you can find all the blogs written by the eminent speakers and doctors who are connected with Shield Connect. Then we have a webinar sections where you can see upcoming webinars and past webinars detail. So when you click on today's webinar, like if you click on see more for today's webinar, you just have to register through your email ID and you have to just join, and you will able to see the webinar for the today. So this is a window where you can see our webinar. And delegates, this is the comment section where you can post your queries so we can have a Q&A session with our speaker for the day at the end of the webinar, and you can also give your feedbacks. So we go to second section, that is the past webinar. You can find all the webinars that we have conducted till now on this page. So you can also go through the different topics that we have covered on this page. Then we have the awareness pages like PCOS awareness pages, menopause, GDM, respiratory immune, COVID-19 page, thyroid awareness page. So if you check like a respiratory immune page, you will find the blogs related to respiratory immunity advertised by Rudibin Mu. And we have the COVID-19 page where you can find blogs and videos of webinars related to COVID-19. And we have the Our Leader section, KOLs section page, where you can find all the profiles in detail of our speakers who are connected with Shield Connect. So now let me give introduction of our speaker for the day, Dr. Mrigank Mishra. So sir is recently joined as a resident physician in Department of Pulmonary Medicine in Assam Medical College and Hospital and in Assam. Sir has also been part of Aditya Multi Specialist Hospital in December 2018 as a consultant pulmonologist. Sir had also specialized in allergy, asthma, and immunology from Vallabhbhai Patel Chest Institute in New Delhi in June 2018. Sir also worked as a senior resident cum fellow in the Department of Respiratory and Sleep Medicine in Medanta Medicity Hospital in Gurgaon. And sir also worked as a senior resident in Department of Critical Care Medicine in Fortis Memorial and Research Institute in Gurgaon in August 2017 to November 2017. And sir has also published various articles like effect of telmisartan on lung volumes, emerging role of transesophageal echocardiography in severe chronic obstructive pulmonary disease. Sir has also published case reports like a case of central trachea mass diagnosed as endobronchial tuberculosis in 2017. Sir has also completed thesis on comparison of cases of pleural effusion in the elderly and adult population. Sir has also presented one scientific paper at NetCon 2015 and two scientific papers at NEPCON in 2016, and also presented scientific posters at HSICon 2015, NEPCon 2015, and NEPCon 2016. Sir has attended basic life support and advanced cardiovascular life support provider certificate from Indian Institute of Emergency Medical Services from Kottayam, Kerala in March 2016 and co-hosted RNT-CP sensitization program in Sri Aurobindo Medical College and PG Institute representing the Department of Pulmonary Medicine. Sir is also qualified in state level surgery quiz in Surgenius 2009 and qualified among top 5 in NEPCON 2016 quiz from Madhya Pradesh and Chhattisgarh zone. Sir has also participated in several interdepartment clinical society meetings, research society meetings, and clinic pathological meetings representing the Department of Pulmonary Medicines, participated in regular seminars and classrooms discussion during MBBS. So, sir, I welcome you on our platform for today's session, and I will hand over session to you. Thank you, sir.
Thank you. Thank you so much. Because this thing, I have made some changes to the presentation, so I'll be sharing the screen now. Is that okay?
Yes, sir. Yes.
Hello. Thank you for such a lovely introduction. I am Dr. Mriganka Madhav Mishra, a consultant pulmonologist from Dibrugarh, Assam. So today I'll be talking about a very relevant and a very important and a quite vast topic, but still, it is difficult to talk over a short period of time, but still I'll try to highlight the most important points out of that which are relevant. The topic is idiopathic pulmonary fibrosis or IPF. So IPF, it is one of the interstitial lung diseases or ILD. Interstitial lung diseases are a group of disease with progressive scarring of the lung tissue. It is a very broad set of diseases come under it. So the classification of ILD or interstitial lung disease that we can see, it is categorized with known cause and unknown cause. Amongst the known causes, we can have connective tissue disease related ILDs, environmental and occupational ILDs, drug and radiation related ILDs, smoking related ILDs, and rare forms like lymphangioliomyomatosis, pulmonary alveolar proteinosis, amyloidosis, alveolar microlithiasis, and heritable disorders, etc. Amongst the unknown cause, where idiopathic pulmonary fibrosis is a part, or IPF, and there are other idiopathic interstitial pneumonias, which we will get into later. Sarcoidosis, idiopathic eosinophilic pneumonias, vasculitis, and rare forms like IgG4 related disease, Erdheim-Chester disease, and etc. Next, there is idiopathic interstitial pneumonias or IIP. So here it is further subdivided into chronic fibrosing IPs or interstitial pneumonias, which include idiopathic pulmonary fibrosis, which is our topic of IPF. Other disease in this group is non-specific interstitial pneumonia or NSIP. Amongst the acute or subacute interstitial pneumonias, there is cryptogenic organizing pneumonia, which we commonly call COP, acute interstitial pneumonia or AIP. There are smoking-related interstitial pneumonias like respiratory bronchiolitis related ILD or RBILD, or an desquamative interstitial pneumonia or DIP. Then there are rare idiopathic ones like the lymphocytic interstitial pneumonia or LIP, and there is pleuroparenchymal fibroelastosis. Now, idiopathic pulmonary fibrosis or ILD. It is a chronic, progressive, age-related interstitial lung disease. It is of unknown origin with an average life expectancy of 3 to 5 years after diagnosis if it remains untreated. It is characterized by relentless scarring of the lung parenchyma, leading to reduced quality of life and earlier mortality. It occurs primarily in older adults. It is characterized by progressive worsening of dyspnea and also the lung function. It is associated with very poor prognosis. Now the epidemiology. The incidence ranges from 3 to 26 per 1 lakh per year. The prevalence of preclinical and undiagnosed ILD is estimated to be 10 times that of clinical recognized disease. This is a huge factor in case of IPF and ILD. That is, many of the diseases remain undiagnosed, and so it cannot be categorized like that. So the incidence that we see, many of the undiagnosed cases are left out. IPF is the most common form, representing at least 30% of the incident cases. Now, the risk factors for the disease. The most important risk factor is cigarette smoking. Usually more than 20 pack years, cigarette is a very huge risk factor for idiopathic pulmonary fibrosis. Environmental exposure, like exposure to metal dust, wood dust, farming, hairdressing, stone cutting, or livestock exposure. Other than that, microbial agents like Epstein-Barr virus, cytomegalovirus, human herpes virus 7, human herpes virus 8, and also gastroesophageal reflux, which via microaspiration can be a very huge risk factor. The genetic factors. For familial IPF, it is less than 5%, and when it's autosomal dominant with variable penetrance. It has chromosome 14 linkage, SFTPA2 mutation is there. For sporadic IPF genetics, polymorphism of genes encoding the cytokines. Now, the pathogenesis of pulmonary fibrosis. The known pathogenesis of pulmonary fibrosis, there is exogenous and endogenous stimuli like dust, fumes, cigarette smoke, autoimmune conditions, or there may be drugs, infections, radiation, or other disease, which leads to microscopic lung injury. It is separated partially and temporarily. It leads to wound healing. And after wound healing, if it is intact, then there is lung homeostasis. Wound healing, if it becomes aberrant, then it can lead to pulmonary fibrosis. Also, associated genetic predisposition and autoimmune conditions may further exacerbate it, elevate it. Now, a very defining thing about the pathogenesis of IPF is that the prevailing hypothesis for the pathogenesis of IPF was that the inflammation leads to fibrosis. But now with many researches, studies, the evolving hypothesis has become that fibrosis usually results from epithelial injury and abnormal wound healing. Inflammation does not play such a major role. But still, to further confirm it, we have been having a lot of studies for IPF now. Now, the clinical features of IPF, the symptoms usually affects adults of 6th or 7th decade, that is above 60-year-olds. There is huge predisposition of males. It is very common in males compared to women. There's unexplained exertional dyspnea with dry cough, with usually a history of smoking. There can be constitutional symptoms like weakness, weight loss, loss of appetite. Fever is a rare symptom. Now, the clinical features of IPF. A very important clinical sign for diagnosis of IPF is clubbing. 25 to 50% of patients develop clubbing. There can be cyanosis, peripheral edema. In chest auscultation, a very characteristic dry and inspiratory Velcro pulse is heard. It is seen in 80% of the patients, and it is prevalent mainly in the lung bases. There is accentuated pulmonic second sound, right ventricular heave may be heard. And there are also signs of cor pulmonale can be seen. Radiology in IPF. Now, an abnormal chest radiograph is often the first indication of underlying ILD. There are peripheral reticular opacities with a net-like appearance of linear or curvilinear densities, mostly at the lung bases, which is quite characteristic. But if there's advanced disease, we can see coarse reticular pattern or multiple cystic or honeycombed areas. This correlates with advanced fibrotic disease, and thus it correlates with a poor prognosis of the disease. There's reduced lung volume, which is usually evident, and pleural abnormality is quite uncommon. So if we see pleural abnormalities in a patient who we are suspecting to be IPF, so it's better that we have a few differential diagnoses also, because we should look for other diagnosis also for such a case if there are pleural abnormalities in it. Now, HRCT, or high resolution computed tomography, it is a very hallmark part of diagnosis of ILD and IPF also. Patchy, predominantly peripheral subpleural bibacillar reticular abnormalities with architectural distortion and honeycombing is seen, which is referred to as UIP pattern or usual interstitial pneumonia pattern. Honeycombing, that is clustered cystic air spaces, typically comparable diameters of 3 to 10 millimeters is usually seen. There can be traction bronchiectasis and bronchiolectasis. This is usually in severe cases. The ground glass opacities may be in variable amount. There is 90% accuracy with usual interstitial pneumonia in HRCT for a diagnosis of idiopathic pulmonary fibrosis. If there is coexistent pleural abnormalities, micronodules, extensive ground glass opacities, peribronchovascular distribution, and alternative diagnosis also should be looked for. Now the pattern, UIP pattern of diagnosis that we see, HRCT criteria for a UIP pattern. UIP pattern, for us to call it a UIP pattern, all 4 criteria should be matched. That is subpleural basal predominance, reticular abnormality, honeycombing with or without traction bronchiectasis. And along with that, the 4th point is that there should be absence of findings listed as the points which are inconsistent with UIP. That we'll see in the next thing. For possible UIP pattern, 3 criteria should be met. That is subpleural basal predominance, reticular abnormality, and absence of findings listed as inconsistent with UIP, which is in the 3rd column. So now the findings which are inconsistent with a UIP pattern, any of the 7 criteria, it is upper or middle lung predominance, a peribronchovascular predominance, extensive ground glass abnormality. It is which is more extensive than the reticular abnormality, which is quite inconsistent with UIP pattern. Diffuse micronodules, bilateral predominantly in the upper lobes. It is not very characteristic of IPF, so it is inconsistent with a UIP pattern. Discrete cyst, like multiple bilateral, away from areas of honeycombing. Mosaic attenuation or air trapping, bilateral in 3 or more lobes. Peribronchial or lobar consolidation. These findings, any of the 7 criteria, if it is matches, it is inconsistent with UIP pattern. Now the diagnosis of IPF requires, first it requires an exclusion of other known causes of interstitial lung disease. For example, domestic and occupational environmental exposures, connective tissue disease, and drug toxicity. Second, it requires the presence of a UIP pattern on HRCT in patients not subjected to surgical lung biopsies. Specific combinations of HRCT and surgical lung biopsy pattern in patients who are subjected to surgical lung biopsy. The other diagnostics for IPF are lung biopsy, surgical lung biopsy, which it is not feasible to do for all the patients, but still it is a very important diagnostic tool. Histopathological criteria for UIP, combination of HRCT and histopathology for diagnosis of IPF, pulmonary function testing, bronchoalveolar lavage, and transthoracic echocardiography. Now, bronchoalveolar lavage or BAL has been an immensely useful research tool in idiopathic pulmonary fibrosis. However, the role of BAL in the clinical diagnosis, it remains limited. The increased numbers of neutrophils in BAL fluid are found in 70 to 90% of all patients with IPF, and increased numbers of eosinophils in BAL fluid are found in 40 to 60% of all patients with IPF. The absence of BAL fluid lymphocytosis is important for the diagnosis of IPF. Now, appropriate analysis of BAL fluid may demonstrate the presence of infection, malignancy, alveolar proteinosis, eosinophilic pneumonia, or occupational dust. BAL fluid neutrophilia has also been demonstrated to predict early mortality. Studies of BAL matrix metalloproteinase levels suggest that MMP1 and MMP7 are increased in patients with idiopathic pulmonary fibrosis, and that MMP7 levels may correlate with disease severity also. Now, the natural history of IPF. It is at the time of diagnosis, it is not possible to predict whether patients will have a slower or faster rate of decline, which is also a very tricky situation for a clinician. It may be a rapid progression course, there may be slow decline, or the patient may remain stable for a long time, then deteriorate suddenly. Now, IPF, a very important feature of idiopathic pulmonary fibrosis, that it is usually accompanied by comorbidities also. The pulmonary comorbidities that are seen are, it may be parenchymal, like lung infections may be there concomitant, and also lung cancer can be associated with idiopathic pulmonary fibrosis. There may be pulmonary vascular comorbidities like pulmonary embolus or pulmonary hypertension. Amongst the extrapulmonary, amongst cardiac, there's heart failure with preserved ejection fraction, coronary artery disease, endocrine abnormalities like diabetes, hematological abnormalities like anemia, polycythemia, gastrointestinal like GERD or gastroesophageal reflux disease, which is quite commonly associated with idiopathic pulmonary fibrosis. Psychiatric infestations may be there, musculoskeletal like osteoporosis may be there, or related medications can also be there. So now, how to treat IPF? We know that there's no curative treatment other than a lung transplant. The aim of treatment is to slow the rate of progression of IPF. We need to monitor the change in lung function, that is FBC, and management of comorbidities is very important. Also, rehabilitation and palliative care. The proposed pharmacological management of IPF is for mild to moderate disease with FBC more than 50% and DLCO more than 35%. We go for PIRFENIDONE or nintedanib. And there are more molecules in clinical trials, which we'll discuss later. And if the disease is severe disease, that is FBC less than 50% and DLCO less than 35%, we need to go directly for lung transplantation. So if it is mild to moderate disease, we start with PIRFENIDONE or nintedanib. We assess in 6 to 12 months. If we see that there is worsening with decrease in FBC more than 10% and DLCO more than 15%, then we should consider the patient for lung transplantation. After assessing for 6 to 12 months, if we see that there is stabilization or improvement, there is decrease in the FVC less than 10% and DLCO less than 15%, we may continue the treatment with either PIRFENIDONE or nintedanib as was given previously. Now, PIRFENIDONE. It is a name like we have heard quite a lot over the last 2 years. So it is a novel antifibrotic agent. It is anti-inflammatory. It also has TGF-beta antagonism. It was the first licensed treatment for IPF in Europe. It is recommended for mild to moderate IPF. It slows the disease progression. The usual dose is 267 milligram 3 times daily, which is increased weekly to reach 801 milligram 3 times a day by the 3rd week. We also usually see that some patients, based on their weight, or they're not able to tolerate, practically if we see, many clinicians would also know, many patients are unable to tolerate a dose of 2400 milligram daily. So we at least try to give them at least 1600 mg, that is twice a day of 801 mg, at least, which can be if they're tolerating it, because giving a very lower dose is also not very feasible for idiopathic pulmonary fibrosis. That is, it won't help that much. The side effects are skin rash, gastrointestinal symptoms, photosensitivity, and liver impairment can be seen. Now, the next molecule, nintedanib. It is a tyrosine kinase inhibitor. It targets the PDGF, BGF, and FGF receptors. We had seen in the clinical trials, Impulses 1 and Impulses 2, nintedanib slowed the disease progression by significantly reducing the rate of decline in FVC. The usual dose for this is 150 milligram twice a day. The major adverse effects are almost similar, and it is mainly gastrointestinal and hepatic. Now, there are recommendations against the use and for the use of a few agents for the treatment of idiopathic pulmonary fibrosis. For a recommendation against the use, there's strong recommendation against the use of anticoagulation, imatinib, combined acetylcysteine and azathioprine and prednisone, selective endothelin receptor antagonists like imbrisartan, corticosteroid monotherapy, colchicine, cyclosporine A, interferon gamma 1 beta B, and etanercept. And there is, against the use, there are weak or conditional recommendation for sildenafil, dual endothelin receptor antagonists like macitentan, bosentan, acetylcysteine monotherapy, mechanical ventilation in patients with respiratory failure due to IPF, and treatment of pulmonary hypertension associated with IPF. These are weak recommendations against the use. Now, recommendation for the use of the following agents for treatment of IPF. Strong recommendations, there are only 2. That is long-term oxygen therapy in patients with IPF and clinically significant resting hypoxemia, and lung transplantation in appropriate patients. Even PIRFENIDONE and nintedanib have a conditional and weak recommendation for the use, but these are recommendations for the use of patient for treatment of IPF. Other and weak and conditional recommendations include pulmonary rehabilitation, corticosteroids in patients with acute exacerbation of IPF, and treatment of asymptomatic gastroesophageal reflux. Now, some non-pharmacological treatments for IPF, that is supportive treatments. Supportive treatments include smoking cessation, breathlessness management, pacing handheld fan, specialist clinic, pulmonary rehab and exercise, improved strength and walk distance, and palliative care services. Oxygen therapy. It is not for everyone with IPF, but people who are limited by low blood oxygen. Different types of oxygen therapy that we can give are long-term oxygen therapy, which is the patient continuously is on oxygen. Oxygen for exercise, that is, patient requires oxygen only when during exertion or during exercise. And short burst oxygen, just taking oxygen for a very short time or suddenly when the patient is having shortness of breath, then he can take a short burst of oxygen. Now, the treating the cough in idiopathic pulmonary fibrosis. We can do it by cough suppression techniques, physiotherapy, clearing the phlegm with mucolytic agents, treating gastroesophageal reflux disease simultaneously, which also helps in treating the cough, and cough suppressant medications. And along with that, we should also prevent the chest infections. This we can do by vaccination, that is flu vaccination and pneumonia vaccination, and prompt treatment of infection with antibiotics. Now the staging and prognosis. Identifying patients with increased risk of mortality within 2 years to consider lung transplantation is of utmost importance in idiopathic pulmonary fibrosis. We'll see a few factors, baseline factors and longitudinal factors. The presence of one or more of these factors, it correlates with an advanced or end-stage disease. These are the indicators of increased risk of mortality in IPF. The baseline factors, if we see them during the while diagnosing IPF only, the baseline factor, that is the level of dyspnea if it is more, DLCO of less than equal to 40%, saturation less than 88% on 6-minute walk test, extent of honeycombing is severe on HRCT, there is associated pulmonary hypertension, and there can be concomitant emphysema. Amongst the longitudinal factors which we need to assess after starting treatment, that is, we see for increase in the level of dyspnea, decrease in FVC more than equal to 10%, decrease in DLCO more than equal to 15%, and decrease of more than 50 meters while walking at a normal pace in the 6-minute walk test, and worsening of fibrosis on the HRCT scan. Now, apart from the current undergoing treatment, we can also see a few novel approaches for IPF treatment. These include stem cells. Mesenchymal stem cells represent multipotent cells that are easily harvested from many tissues, such as adipose tissue, peripheral blood, bone marrow, and umbilical cord. Several lines of experimental evidence suggest strong anti-fibrotic, anti-inflammatory, and immunomodulatory effects for mesenchymal stem cells, both through paracrine signaling and potent differentiation capacity. Preclinical studies demonstrated that administration of MSCs was associated with downregulation of TGF-beta signaling, significant improvement in lung histopathology, extent of fibrotic lesions, lung collagen content, and reduced bronchoalveolar lavage neutrophilia. Despite relative enthusiasm, there are still major concerns on the therapeutic role of stem cells in IPF, mainly arising from experimental data suggesting a detrimental role for MSCs within a pro-fibrotic microenvironment. Future studies on MSCs are hampered by the 2014 FDA approval of nintedanib and PIRFENIDONE, leading to major delays or even failures to meet enrollment timelines. Another novel approach is the inhalational route. The current treatment for IPF is usually via the oral route. Delivery of treatment directly to the lungs has the potential to maximize the therapeutic exposure in regions at greatest risk of disease progression, whilst minimizing the systemic exposure and thus reducing the potential for adverse effects. Inhaled treatments are already the mainstay for obstructive lung disease such as asthma and COPD, but have been poorly studied in IPF. A recent study using radiolabeled salbutamol has confirmed that inhaled drug delivery in IPF is feasible, but is impacted by severity of fibrosis and the particle size. Another study of a novel compound targeting the integrin AV beta-6 used positron emission tomography imaging of the integrin to demonstrate effective delivery of the drugs to regions of fibrosis. Study of an inhaled galectin-3 inhibitor showed downregulation of the receptor in alveolar macrophages in a dose-dependent manner. Overall, these data confirm that inhaled administration of drugs is feasible in IPF, and this route may be important in minimizing side effects for patients. So, summarizing it, the key points that we need to know regarding idiopathic pulmonary fibrosis or IPF is that IPF is a rare disease, but with a very high mortality. The median survival is worse than most cancers also. Diagnosis is based on HRCT and or histological evidence of UIP, while known causes are also ruled out. Early and accurate diagnosis is important, as available treatments like PIRFENIDONE and nintedanib are tested on mild to moderate IPF. New evidence suggests efficacy of PIRFENIDONE and nintedanib in delaying the decline in lung function and reducing exacerbations also. There's evidence against the use of steroids and immunosuppressive agents in IPF. However, acute exacerbation of IPF should be treated with supportive care, and steroid use in this clinical setting may be beneficial. Non-pharmacological treatment include long-term oxygen therapy, pulmonary rehabilitation, and supportive care. Eligible patients should be referred for lung transplant evaluation as soon as possible. Screening should be done for pulmonary hypertension, obstructive sleep apnea, gastroesophageal reflux disease, and coronary artery disease. It is very important to have end-of-life care and palliative care services also for IPF. Thank you.
Thank you so much, sir, for giving all the detailed information regarding IPF. So now let me ask questions from our delegates. So, sir, the first question is, what is the life expectancy of someone who is suffering with IPF?
The life expectancy, it varies from if it is left untreated, it is usually only 3 to 5 years. But if treatment has been started promptly, and while it is in mild to moderate IPF only, if the treatment has been started promptly, and if we monitor, assess properly, then we can have a life expectancy of at least 10 years. We can see if it is followed up properly, and if in case we see that there is deterioration, we can consider for lung transplantation also early, then we can have a longer life expectancy.
Second question was the same, that can someone with IPF get lung transplantation? And sir, if yes, then what is your view on this method of
lung transplantation? As I said, is the only definitive treatment for this thing, idiopathic pulmonary fibrosis. All other treatment that we have seen till now, the ones that have been accepted till now, are only for slowing the progression of the disease. But all patients are not eligible for lung transplantation also. If there's severe associated other diseases also, like obstructive, this thing is the chronic obstructive pulmonary disease also there. Such patients, it is difficult to consider for lung transplant also. But still, if we see that IPF is the predominant deficit, and if clinically the patient is still okay, then we can consider for lung transplantation. And lung transplant has a comparably good, if it is left untreated, from that it is quite better to have a lung transplant.
So, sir, then what is the then life expectancy? Does it increases for the
it
patient?
increases. Actually, even till now also in India, we haven't had a lot of lung transplantation. By now it has, like we have seen quite a lot, but compared to liver or heart transplant or kidney transplant, it is very less lung transplants, because it is a relatively newer thing, the lung transplantation. So we're still seeing patients. It is like ongoing research has been going on, but with lung transplantation, we have seen patients living up to 8 to 10 years. It has been seen.
Great. Then, sir, one more question, that like IVF is more occurring in the male patients. So does it affect male sexual life? Like, does it cause any kind of erectile dysfunction in males having IPF?
Erectile dysfunction can also be seen, usually even if there's no erectile dysfunction, but the sex life of the patient may be hampered by the shortness of breath, the acute oxygen dependency, all that may hamper. Anyways, it will hamper the overall this thing, quality of life of
Quality
the
of
patient.
life. Yeah. And sir, if some patients come to you, then how would you explain them easily that difference between IPF and COPD? If they get
It is like,
confused.
the most important thing to say is that it is, there's no this treatment for that. It is anyways a progressive disease. And the most important thing to mention is that if treatment is not done properly, it will lead to end of life within 3 to 5 years if treatment is not done, if it is left untreated. So with that criteria and with that point, we have to move forward. The patient and his relatives also should know well enough the severity, the critical condition of the disease. So based on that, so that they are also alert for it. And if needed, so because indecisiveness from their part also can delay the patient's condition and worsen the patient's condition. So it is important that if it is diagnosed early, even from the first go, the patient as well as the attendant should know about the problem properly and act accordingly. Give it full importance.
So now this is the COVID era. So some two questions are regarding the COVID. So how harmful was COVID-19 virus effect on the patient with IPF condition?
COVID-19 virus, as we had seen, IPF patients, to if it is there, IPF is definitely a very severe comorbidity for a COVID patient. So it is very, during the first and second wave, IPF was a very critical comorbidity. And with that, patients with IPF having moderate to severe COVID, usually life expectancy was not good and it was poor prognosis only. But during the third wave for mild infections, we have not seen any major increase in the deaths of patients with IPF. So it can't be correlated that well. But IPF patient already with a IPF, if they are having moderate to severe pneumonia, then definitely prognosis is very poor.
Then the second question is that like post-COVID symptoms are coming to the patients, fatigueness and everything. So is there any chance of like post-COVID IPF in any patient who recovered from COVID?
Post-COVID, as in the IPF won't be there. IPF is usually a idiopathic thing. The risk factors may lead to it, but if it is after COVID, then it will be a post-COVID fibrosis. So the mechanism is not fully same, but because the knowledge about COVID and post-COVID, it is still evolving, and we have been following up. It's only been 2 years, so we have been following up patients now. So long COVID patients, we are still in the process of knowing whether antifibrotics like PIRFENIDONE, nintedanib are working on not on them. So many clinicians prefer, even though there is no discrete evidence till now that the treatment strategies for IPF will work in post-COVID fibrosis also. It is not clearly evident now, but still many clinicians prefer to give antifibrotics even for post-COVID fibrosis because it's always better to give than, because it doesn't have a very bad side effect profile. So it's better to, many clinicians prefer that it is better to give in post-COVID fibrosis also. But that is upon the clinician's discretion only. Till now, there's no concrete evidence.
Thank you for giving all the answers. Now, the questions are somewhat regarding the treatment and diet related. So the first question is that does curcumin kind of a herb bioactives have effect on such kind of disease? IPF?
There may be, but IPF is such a disease that curcumin, maybe we'll later on get to know if there's more research on it. Like in preventing a disease like that, we might have some role, because even the this thing. Curcumin, usually if we see that in inflammatory diseases, it has a lot of role. But for IPF, it is being seen that the pathogenesis, the hypothesis that we were having, it has evolved now, and like we are getting to know that inflammation is not such a major factor for IPF, which was previously we had thought that inflammation is the main factor leading to fibrosis. So with emerging more evidence, we might have something related to that.
Second question is caffeine intake good for lungs? It is the normal questions.
Caffeine intake, it is like caffeine is the molecule. Caffeine is very similar to a very important bronchodilator that like this thing, deriphyllin, etophylline, theophylline. It is very similar. The actions are very similar to caffeine. So definitely caffeine has a role in bronchodilation of lungs.
The last question is, what kind of diet would you recommend to the patients who are coming with this IPF symptoms? Or
the diet is not very different from to avoid any exacerbations and all. We should avoid any cold items or things from the fridge should be avoided. And because there is also gastroesophageal reflux disease along with IPF, so we should avoid spicy or too fried food, salty food. It should be avoided a little bit. Normal diet is fine.
Okay, sir. And sir, to increase the quality of life, such a patient can have exercise like yoga or any breathing exercises?
They can. Yoga is a good thing for them. For mild to moderate IPF, yoga is quite a good exercise thing. Yoga, meditation, a little bit of physiotherapy, chest physiotherapy, lymph physiotherapy, deep breathing, and a mild, some mild exercise. Even some amount of mild weight training is also good for some patients because it helps to keep the proper functioning of the limbs. So overall, for mild to moderate patients, yoga is a good.
Thank you for giving all the answers to these questions, and we were glad to have you on our platform for today's session.
Thank you.
And we would also like to have some new topics with you on our platform also, sir.
Sure.
Thank you, sir. So,
thank you, Mishra sir. Thank you.
Thank you.
Thank you today for the wonderful presentation also.
Thank you so much.
Clarified all the queries. I hope your queries, solutions to fruitful to your all the audience. Sir. Thank you, Nishanji, for moderating the session. Thank you so much.
Thank you.
Have a nice evening. Thank you.
Thank you, delegates, for joining.
Thank you so much.
Have a nice evening.